My name is Dr. Ishita Singh, and I head the nuclear medicine department at Fortis Gurgaon. And today it's going to be a practical interpretation of renal scans for. It's actually a nephrourologist. I think all of you are training nephrologists, is it? So, but there's a lot of overlap. So, we're just going to quickly go through the basics of renal scintigraphy and the nuclear medicine techniques which are available for the evaluation of the kidney, and then show you some interesting cases. So, uh, please feel free to stop me at any point. Let this be an interactive session. How many of you are exposed to nuclear medicine procedures? Huh? All of you are from Delhi, isn't it? I can't believe any of you have not seen DTPA scan and you've not. Okay, all right. So, okay. So, when we talk about the most common investigation in nuclear medicine, which you will be writing in your practice or which you will be probably questioned on in your exam, that is the renal scintigraphy. So renal scintigraphy is a technique by which we look at the function of the kidneys, and often we give a diuretic in the middle of the study, and these scans are usually done for the evaluation of any obstruction, also to look for the glomerular filtration, to look for transplant evaluation, to assess the renal function prior to a renal transplant in a renal donor, to look for any renal scarring in cases of UTIs, and pretty much, I mean, those are the, we will come to the indications. So, it's called a renal scintigraphy. Why scintigraphy? Scintigraphy because we are injecting a radioisotope inside the patient. This radioisotope is being taken up by the different cells in the kidney. It may be the glomerulus, or it may be secreted by the tubular secretion, or it may be protein bound to the cortical proteins. And these once these can we switch off the mobiles, please? Yeah, thanks. So once these isotopes are taken up by the kidney, they emit the radiation, which is then caught or detected by a camera called the gamma camera. And because these radiations, they emit photons or light, and hence the word scintillation. So that is why nuclear medicine procedures are often called scintillation scans or scintigraphy. So that is the genesis of the word diuretic renal scintigraphy. Diuretic because we give some diuretics in the middle. Now, there are various radiopharmaceuticals which are used for doing these scans, and the most common ones are DTPA, MAG3, EC, DMSA, and GHA. So, these are the normal radiopharmaceuticals which would be used in your routine practice. Now, DTPA is an inulin analog. So, inulin is a polysaccharide which is completely excreted by glomerular filtration. So, DTPA is a tracer which is almost completely excreted by glomerular filtration. MAG3, on the other hand, this is something which is used more often in the United States, and that is excreted by tubular secretion. We have an Indian analog of MAG3 also called EC, and especially in children, we use a lot of EC. Now, EC is also secreted by tubular secretion. Then we have two agents called DMSA and GHA. These are protein bound, so they get attached to the megalin tubulin receptor complex, and they are internalized in the proximal tubular proteins, and they give us a morphological imaging of the kidney. So while the DTPA, MAG3, EC, these are used for functional imaging, the DMSA gives us more morphological imaging. So when you're trying to look for scarring, okay, or you're trying to see how much of the renal parenchyma is being occupied by renal SOL, so you would use something like DMSA or GHA. Now, we inject all these tracers intravenously, right? So they go into the blood, and the kidney then extracts them in the first pass. Now, the higher the extraction fraction of the kidney, so normally how much of the cardiac output goes to the kidney? 20%. So whatever you're injecting, 20% of that reaches the kidney. Okay? So then the kidney has to extract it in from the bloodstream. Right? So amongst all these tracers, there is a differential in the amount of extraction which the kidney can do. And depending on the amount that the kidney can extract is the quality of your imaging. So, like for instance, DTPA, while it is a beautiful agent because it is a pure glomerular filtration agent and you can actually calculate the GFR in absolute numbers, the problem with DTPA is that the first pass extraction is only about 20%. So, whatever you are injecting, about 20% of that goes into the kidney, and only about 20% of that is extracted by the kidney from the bloodstream. Right. So that is the reason why if a person has got a high creatinine or has got deranged renal function, so a creatinine beyond 4 would not give you good quality images using DTPA. Whereas if you look at say MAC3 or ECG, the extraction from the first pass by the kidney is much higher. So you can use these tracers even in situations where your renal function is deranged. So even if your creatinine is more than 4, you can get a good idea of the effective renal plasma flow by using an agent like LLEC. Right? So unlike DTPA, when you use tubular secreting agents, you get a value called ERPF. So it is important to know that so many times we will get requisitions saying that do a MAC3 and give us the GFR, right? So it is not possible with MAC3 because there you're getting something called effective renal plasma flow. Whereas with DTPA, which is a glomerular agent, you get a GFR. With agents like DMSA or GHA, which are protein bound, you will not get a GFR value. So you would only get a differential uptake. So if you have, say, a right kidney which is scarred and a left kidney which is normal, you can get a differential contribution that, okay, the right kidney is contributing this much and the left kidney is contributing this much. But you cannot get an absolute number of a GFR. So these are the basic things which you have to understand. So 4 agents, DTPA, dimercapto, triamine, pentaacetic acid. So I don't think anybody is going to ask you these names, but it's interesting to know that. So it's diethylene triamine pentaacetic acid. MAG3 is mercaptoguanidine. So again, MAG3 is an agent which is a tubular agent, and so on and so forth. Now, how is it done? So you can see. I'm sorry. So this is a gamma camera, right? And here you have the patient who's lying here. This is the gamma camera. Now the kidney is being at the back. The camera is actually below the patient. So you can see this. This is a small baby who's having the scan, and you can see this. The scanner is kept behind the patient. All right. Sometimes when you have a transplant kidney or you have an ectopic kidney, you can also image from the camera on top, right? And the patient is usually placed on this couch. An intravenous line is placed in the hand, and the tracer is injected intravenously. And while it is being injected, the camera continues to take and acquire images. It's something like if all of you have seen IVPs, the way IVPs were done. This is the, I mean, in a way, it is very similar to the way IVPs is done, except that here, unlike IVP, where you're injecting a contrast and then exposing the patient to X-ray radiation from the outside, here the tracer, which is inside the patient, is actually emitting the photons, and the camera, these detectors, these are actually just picking up the rays which are emitted by the patient, right? So the radiation is not in the machine, it is in the patient. So how is it done? Typically for all renal scans, patient should be well hydrated. Does not need to be overhydrated, but should receive an additional oral fluid load of about 5 to 10 ml per kg of body weight, about 30 to 60 minutes before the scan. No special diets. Some say that if you give a protein diet prior to a DTPA scan, the GFR may be slightly raised. Diuretics should be withheld on the morning of the study. Pregnancy obviously is a contraindication because we are dealing with radiation. Breastfeeding, interruption of breastfeeding is not required, and the radiation exposure to the fetus is, or to the baby, to the breastfeeding baby is very less. And often we just ask the patient to withhold feeding for one feed just for because of the proximity of the baby, because the mother is radioactive. You keep the baby in close proximity, the baby gets exposed by the proximity. DTPA is not excreted in breast milk, or none of these agents are excreted in breast milk. So it is only for the proximity that we ask the patient to withhold breastfeeding for an hour. And this is what a normal DTPA scan looks like. If you have ever seen a DTPA scan, you would see it has some images like this, and it has some curves, and it has some numbers. I don't know whether you can see it. It seems a little blurred. Anyways, we will come to those parts separately. Now, when you talk about furosemide intervention is a Lasix intervention, is a very important part of a renal diuretic scan. All right, and there are different protocols which are used for giving furosemide. So typically, a DTPA scan or a renal diuretic scan, it works for about half an hour. So it's about a half an hour scan. So we inject the tracer and immediately start taking images, and the patient is kept on the table, and continuous dynamic images are acquired for a period of about 30 minutes, right? Now you can give the Lasix normally either in the middle of the study, which is F plus 15. So F is the point of starting the tracer, and you can, most common procedure which is used is F plus 15. So the idea is that you give the diuretic once the tracer has come to the renal pelvis. So the tracer is extracted by the renal cortex. It goes through the cortex, through the medulla, into the renal pelvis, and the Lasix is given to facilitate subrenal drainage. So you actually, somewhere in the middle of the study, you see the arrival of tracer into the pelvis, and that is the point at which you give Lasix. Okay. Now, in certain situations where you have a large capacious pelvis, a patient has had a pyroplasty, but there's still a large capacious pelvis, or if you feel that there is some functional obstruction, you can actually give Lasix 15 minutes prior to starting the investigation, right? In the current era, usually that is not done because what happens is that it changes the, we also calculate the differential renal function at about 5 minutes into the study. Now, if we give Lasix up prior to starting the study, it may change the differential renal function, and it does not really give us a technique by which we can assess the response to furosemide. So if you see that a pelvis has filled up and then you give Lasix and the pelvis clears out, you know that this patient is responding to the Lasix. But if you've given Lasix prior to starting the study, so then it becomes sometimes difficult to actually assess whether this is the effect of Lasix or whether it is spontaneously draining. All right. Now, in pediatrics, sometimes F0 protocol is preferred simply because you can give the Lasix and the radioisotope in the same injection. If you give injection in the middle of the study, the child may move and your renal curves may get spoiled. There are different protocols of how much Lasix to give. In the earlier protocols, we used to give, like when I was a student, way back 25, 26 years back, we used to give a higher dose of Lasix, so which we would give about 80 milligram or 1 milligram per kg body weight. But it was found that the hypotension which the Lasix created, the high dose of Lasix created, that interfered with the renal parenchymal transit and the renogram curve, and actually we started underestimating the renal function, and so the protocol normally today is to give about 20 milligram of Lasix along with a 400 ml of oral fluid bolus, either intravenously or orally at the start of the study. Now, whenever we talk about uh, trying to calculate the renal excretion or trying to calculate the renal function, we draw something called the region of interest. Now, if you when you read your things about DTPA, you will find there is a lot of talk about whether the region of interest should include only the cortex or should include the pelvis. So, if you look at this is the kidney, okay, and this drawing which has been done, this is called the region of interest, okay. So we are trying to draw a region of interest and see the dynamics of the counts which are coming from this region. So once you inject the tracer, initially there will be very high counts coming from this region. Then as the DTPA starts getting excreted from the kidney, the counts will come down. Now the question is, should we draw an ROI around the entire kidney, or should we just draw it around the cortex, or should we draw a separate one around the cortex and around the pelvis? So the current recommendation is to draw an ROI which includes the whole kidney, which includes both the cortex and the pelvis, and to do the renal renogram based on that. However, there may be situations where you would want to draw a separate ROI for the renal pelvis, so that to see what is the how is the renal pelvis draining in response to furosemide. And you have something called a renogram curve. Now this renogram curve is a curve which you will often see on your DTPA reports. Now if you look at this curve has got three parts. It's actually got four parts. The first minute is the renal vascular phase, where you just injected into the intravenously, it goes into the heart, it goes into the aorta, and it goes into the renal artery. There's a renal blush, and that's your first pass. So you actually see the tracer in the renal vessels, and so initially there would be a blush which is for about 1 minute, and the first pass extraction starts at about somewhere between about 20 seconds to about a minute, right? So that is the time when the renal cortex starts extracting the tracer from the renal, from the blood, from the blood flow, and it starts building up. So the first part, which is the A part, is actually the vascular phase, and that kind of crosses over with the beginning of the renal parenchymal uptake phase. Somewhere between about 3 to 5 minutes is the time when there is a maximum peak renal uptake, which means that the cortex is actually extracting the tracer from the blood pool, and then somewhere about 5 to 8 minutes it starts excreting. Okay, and then you have something called the T half max, which is basically the time taken to achieve 50% of drop in counts in the kidney. So if this is your maximum counts and this is 50% of your counts, the time it takes from the start of the study to achieve this 50% of counts is called the T half max. And there's a lot of significance of this T half max, because a lot of issues about whether a kidney is obstructed or not is based on this T half max, right? So it is the time. The T stands for time, half max. So the maximum counts and the time it takes to halve the total number of counts in the kidney. So that is the T half max. Now, if you look at the renogram, so you have to just understand this slide, and then you can understand the renogram. So the initial uptake phase, this is simple to understand, right? So the kidney is extracting the tracer from the blood vessels and from the blood, and it's building up in the kidney. At some point, you reach an equilibrium when the uptake and the excretion kind of becomes equal. So this is called the equilibrium phase. Now in kidneys where there is any obstruction, the excretion or the elimination of the tracer from the kidney does not happen, and the tracer keeps building up in the kidney. So because the elimination is not happening, all the tracer, while it is being extracted from one end from the blood, it is not getting eliminated. So the renogram curve kind of shows an upgoing kind of piece. In kidneys, which are where the excretion happens, when slowly the renogram curve goes down. So this yellow one is a normal renogram curve. So you have the first peak uptake by about 3 minutes. By 3 to 5 minutes is your excretion, and by about 20 minutes into the study, at least 50% of your tracer has already been excreted from the kidney, and you've almost reached baseline by the end of the renogram. Now the others are in a situation where there is a slowing of the elimination, and the more the slowing of the elimination, the steeper the upslope of the curve, right? So there would be some where initially there would be an upslope, and then once it starts going down, it starts going down. So the curve starts to go down. So based on these components, uh, these are the different kinds of renogram patterns, and these are called the O'Reilly curves. So often, if you have, in your Viva, many people will be asked this, that what are the O'Reilly's curves? So O'Reilly's curves are nothing but they are the renogram patterns which define whether a kidney is excreting well, or whether it is obstructed, or whether it is a functional obstruction. So these are the different kinds of curves. So this is the type 1 curve, which is the normal curve. Like what I said, the uptake happens at 3 minutes, 3 to 5 minutes is the equilibrium phase, 5 to 8 minutes is the rapid excretion phase, and somewhere around the 20 minutes of the study, you achieve about 50% of the max, or the T half max, and the tracer is excreted by the kidney by the end of the dynamic phase. Now this dynamic phase is usually about 30 minutes. Now this is an obstructed curve. This is a type 2 curve, right? So in type 2 curve, your renogram pattern is an upgoing pattern. You inject a diuretic somewhere in the middle of the tracer, and despite the diuretic, there is no excretion, and the renogram pattern continues to be on an upslope. So this is a type 2 curve, or an obstructed curve. Now the type 3A curve is the hypotonic curve, right? So the hypotonic curve means where you have a large capacious pelvis, so, or a hypotonic pelvis. So what happens is that initially the uptake is going up, and there is renal accumulation of the tracer in the renal pelvis, and the moment you give Lasix or you give furosemide, it there is an immediate subrenal drainage, right? So you get this rapid drainage once you've given diuretic. So this is a hypotonic curve. You have something, this is called a 3A curve. Now you have the 3B curve, which is called the equivocal curve. So equivocal curve is, sometimes you will get this kind of a curve, again in a post-pyeloplasty setting where you have a large capacious pelvis, or you have some partial obstruction which is there. So in these kind of situations, you will find that initially the curve will show an upgoing pattern. Then as you give Lasix, it shows a downsloping pattern, but it's not as rapid as your 3A curve, right? And then you have the type 4 curve, which is known as a delayed compensation curve. So this delayed compensation curve is usually when you have a high grade obstruction. So here you have, initially when you give Lasix, there is some response of the Lasix, but then again, as the tracer is extracted by the kidney into the pelvis, it starts to build up again. So once the effect of intravenous Lasix passes away, again it starts building. So this is again a obstructed kind of a pattern. So you have the normal, the obstructed, the two which are kind of equivocal, this one being a non-obstructed, mainly a hypotonic kidney, this one is an equivocal curve, and this is a delayed compensation or a obstructed curve again. Now sometimes if your bladder is full, and there would be something called the reservoir effect. So you can see these are the renal images, right? So if you look at these images, if you look at one, you see there is some uptake, which is, there's some little spot here in the chest. So that is the cardiac activity, right? So you injected the tracer, it is in the cardiac blood pool, then it goes into the aorta and it is extracted by the kidney. Okay. Now each of this image is a 1 minute image. So you can see this is about a 21-minute image, a 21-minute study, and each of these images is acquired for a period of 1 minute. So every 1 minute you get one picture, which is the stacking of pictures which have been acquired over the last 1 minute, and their 1 minute images are stacked together to create this kind of a dynamic image. So you have every minute you have one stacked image, which is actually telling you the transit of tracer through the kidney in the last 30 seconds or 60 seconds, right? So the initial this one you can see that there is very little uptake in the kidney. That kind of builds up by the end of the first minute. It builds up more at the end of about 3 minutes. And then somewhere out here you can see that, can you see this little hump in the middle? That is the renal pelvis, right? And so somewhere around the 5th minute, you see the arrival of tracer into the pelvis. And if you look at, okay, now these renal scans are done from the back. So your right is the patient's right, your left is the patient's left. So that is very important to understand, that when you are looking at a renogram, your right is the patient's right. So this is the left kidney, and this is the right kidney. So you can see the heart on the left, and this is the right. Okay. So you can see out here that the left kidney, if you look at the right kidney by about 5 minutes, it starts to drain. And by the end of the study, there is nothing left in the right kidney, the one which is on this side. The left kidney, on the other hand, while it shows initial uptake, the initial uptake is also a little slow, and then it just remains, the tracer remains in this renal pelvis, and even somewhere in the middle where you've given Lasix, even despite that, the tracer remains in the pelvis. Now, you can see that the bladder, this little thing in the bottom, the blob at the bottom. The marker is not showing on the. Is there somebody from there? So the marker is not. So I can see it on my screen, but it's not coming on the projector. Or do you have a
projector is not working for this.
Okay, no problem. Do you have a? Okay, let it be. It's all right. So this is the bladder. Yeah, whatever. It's all right. So that little blob at the bottom, that is the urinary bladder, and you can see that as the tracer exits from the kidney, it fills up into the urinary bladder, and the bladder is kind of getting distended. Now, what happens? This is another study, and here you can see that the bladder is quite full. You can see out here on the image, which is out here, you can see that the bladder, this one, is full, right? Now, the moment you ask the patient to void, the tracer, which was stuck in the renal pelvis in the image, that also clears out. And that is why it is very important to take an image at the end of the dynamic study, which is a post-void image. Because so many times, the functional stasis of tracer in a dilated pelvis will clear out once you decompress the urinary bladder. Sometimes in patients who've got a neurogenic bladder or who've got a vesico-ureteric reflux, you would actually place an indwelling catheter in the bladder, keep it on flow, and then do the renal study to get an accurate assessment of the renal function. Then we come to this concept of T half max. Now, as I said before, T half max is the time taken by the kidney to clear half the maximum tracer activity, and usually it is about 12 minutes in most studies, especially when you are using DTP. Now, traditionally, a T half max of more than 20 minutes was considered to be an obstruction, right? But now we know that it depends on a lot of things. It depends on what radiopharmaceutical you are using. If you are using MAG3 or EC, it will clear out faster. If you are using DTPA, it will clear out a little slower. If the patient is dehydrated, it will take longer to clear out. If the bladder is full, it may take longer to clear out, right? So this entire concept of having a T half max more than 20 being equal to an obstruction is now kind of outdated. But still, as a rule of thumb, we consider that a T half max of more than 20 minutes, and you should be looking for some possibility of a obstruction. Now there are various. I'm sorry, this is a busy slide, but the idea is to apart from T half max, there are multiple other parameters which you can build into your renal dynamic study, which are probably better indicators of whether a patient is having an obstruction or not. So the counts in the post-void image divided by the maximum counts in the kidney normalized for time, and that is usually the most accurate method. If there is one technique which actually tells you whether this kidney is obstructed or not, that is this particular parameter, where you actually calculate what are the post void counts in the kidney versus what are the maximum counts in the kidney. And if you can see that there is a, so if the ratio is 0.18 plus minus point, so about, if there is only about 20% of the tracer retained in the kidney post void, then that means that you have a non-obstructed system. So this is probably the most robust parameter which is used for looking at the excretion pattern of the okay. The other things are also actually just they look at the same thing. So you have something called 20-minute to maximum ratio. So again, that is the ratio of the kidney counts at 20 minutes to the maximum counts normalized for time. Now, why are we saying normalized for time? Radioactivity will always decay, right? So the half-life of technetium, which is the tracer which we use for most of these renal scans, is about 6 hours, which means that every 6 hours, the amount of tracer that we started with is decayed to half. So if we start with 10 millicuries at 10 o'clock in the morning, or at 12 o'clock in the morning, then by 6 o'clock you will have 5 millicurie left in your hand. So the fact that this continuous decay of radioactivity which is happening has to be taken into consideration when you are doing any calculation, right? So you may say that I had 10 millicurie in my kidney at 12 o'clock, and at 12:30 I have 5 millicurie, so we've achieved 50%. No, there is some physical decay also which has happened, so you have to incorporate that also in your calculations, right? Then we have something called the tissue tracer transit time or renal parenchymal transit time. So you will see many times in the reports of your DTPA, you will have this concept saying that there is a delayed renal parenchymal transit time. Now, what do you mean by that? Visual appearance of tracer in the pelvis. So if by about the 10th minute you find that there is tracer which has appeared in the pelvis, then you know that the renal parenchymal transit is normal. If the arrival of tracer in the pelvis is delayed beyond 10 minutes, then you know that the renal parenchymal transit is prolonged. Now that renal parenchymal transit may be prolonged for various reasons. It may be because the patient has some medical renal disease, if there is edema, if there is acute tubular necrosis, if there is acute infection, if the patient is dehydrated, if the patient has been subjected to a contrast injection or has had any kind of nephrotoxic drug. So in all these parameters, so if you do a comparison, this is similar to a resistive index which you see on an ultrasound, right? So anything which causes the renal parenchymal transit to be prolonged will result in a delayed arrival of tracer into the pelvis, and this may often be seen in patients who have a obstructive nephropathy. So once you have the obstructive uropathy, and then if you have an obstructive nephropathy, then the renal parenchymal will be transit time will be prolonged. Some other fancy words like NORA. NORA is the renal activity at a given moment. So that may be the end of renogram, end of fusamide acquisition, or a later image after micturition divided by the renal activity at 2 minutes. So again, what are we doing? We are trying to do a ratio of the amount of activity which is left in the kidney at the end of the study versus the peak activity. And as a rule of thumb, if about 20% of it is only remaining at the end of the study, we know that it's a normal kidney and it has excreted nicely. Okay. These slides are there on the desktop here. So if anybody wants it, please feel free to copy it or use it. Okay. Um, Now coming to the indications. So indications are very simple. Any suspected PUJ obstruction, any obstructive uropathy, whether it is a mega-ureter or a post-ureteral reimplantation, prune belly syndrome in children, horseshoe kidneys, polycystic kidneys, ectopic kidneys, renal transplant obstructions, prior to nephrectomy to assess the contralateral kidney. Then you have the ileal loop diversions, obstructive masses in pelvis. So these may be the common indications for doing a diuretic renal scintigraphy. Now, most of the times we do these diuretic renographies in children. So very few adults actually come for diuretic renography, except for those who either have who are renal transplant donors or in in something like that. So normally it is the children who come to us for diuretic renography, and many of them are the ones who are antenatally diagnosed hydronephrosis. Now, does every child who has been antenatally diagnosed with hydronephrosis need a radionuclide scan? No. So, the first investigation which you do when a child is born is an ultrasound, and you look at the diameter of the pelvic axial system. Now, if the diameter of the pelvic axial system is more than 40 mm, nearly 90% of these kids will require some kind of an intervention. So these are actually the patients who would probably be earlier referred to the pediatric surgeon for doing an intervention. Those who have a pelvic axial diameter of less than 20 mm, just about 11% of them will require any kind of intervention as they go on. So these are the patients whom you can safely follow up. Now, the kids who got a pelvic diameter between 20 to 40 mm of millimeters, though that is the group where who will require a assessment. Now, a radionuclide renogram is usually not indicated for a baby prior to about a month of birth, because there would be renal immaturity which reduces the extraction of the tracer by the infant's kidney. And normally we would recommend that the first scan, if it can wait, should be done not before about 3 months of age, at least not before the first month of birth. And it is predominantly recommended for those who got a indeterminate kind of a value on an ultrasound. So somewhere between about 10 to 20 mm of 20 to 40 mm of pelvic axial dilatation. Those are the ones who may benefit from from a diuretic renal study. Again, for duplex kidney who got a dilatation of one or both moieties, again a diuretic renogram is usually essential. So these are the nice guidelines where for imaging in antenatally diagnosed hydronephrosis. So if you have a unilateral hydronephrosis which you see antenatally, you do a renal ultrasound, and like I said, at 3 months, if the diameter is more than 20 and less than 40, that is the time at about 3 months you can do a renal diuretic study. If the renal function is impaired and if there is a progressive increase in dilatation of the renal pelvis, those are the kids who will need an early intervention. If the renal function is preserved and the differential renal function is not more than 10% different, so it's like normally you will have 50-50, so it should not be more than 40-60 in such a situation. And if your pelvic axial diameter is not increasing, you can safely keep these children on follow-up. Again, if you have, this is the same like I already said, those who have more than, it's written 30, it's actually 40 mm. So those who are more than 40 mm require an early pyeloplasty. those who are less than 20 mm can safely be followed up, and it's the intermediate group which requires repeated study, usually a repeated ultrasound and one MAG3 at the end of 3 months, and probably the second MAG3 or DTPA at the end of 1 year. Again, this is the continuation of the same, and this basically helps us in assessing the renal function and in risk stratifying which are the patients who will require a early intervention. Now, what is the radiation exposure? So, the radiation exposure of a DTPA scan, like I said, it's a radioisotope which you are injecting intravenously. So, the injected dose is about 12 to 24 megabecquerel. So, you say about 1 to 2 millicuries of tracer, and the mean effective dose, if you compare, an IVP will give you something like 3 millisieverts, right? Whereas a DTPA would give you something like 0.03 milligray per megabecquerel. So your mean effective dose is about 0.02 millisieverts per megabecquerel. So you're giving about 12 megabecquerels. You multiply that by 12. So it is far less, almost 500 times less than what you would get on an IVP. So these are very safe studies, and the renal exposure to the child is very less, and even to an adult, the amount of radiation exposure is far less than what you would get in most radiological studies. Now, in adult upper urinary tract obstruction, do we need diuretic renography? Usually not, and usually because most of these patients require who have an obstruction is either because of a renal calculus, which you can see very nicely on a X-ray or a CT, and you don't really need a renogram to look at that. You would often see this because of the lower pole crossing vessel or the aberrant iliac vessel which is crossing the ureter, and in these cases a DTPA scan will help you in deciding which patient requires a stenting and which patient does not. So if you have a non-obstructive system, you can just tell the patient to chill, and if you have a significant obstruction, then we may have to take some necessary action. So can somebody read this scan for me? Now you know how to read a scan. Anybody? So which is the right and which is the abnormal kidney? Let me tell you. Let's start with that. Which do you think is the abnormal kidney? The right or the left?
Right.
Very good. Really? So what's happening here? Somebody read it. Anybody?
In the right kidney, even at the end of the study, the tracer is still is there, which means that there is obstruction and it is not getting into the bladder.
Very
So
good.
right kidney is obstructed.
Very good. So if you look at the initial study, you find that the right kidney is showing some medial cortical thinning. So if you look at the first image up there, you find that the left kidney is showing a much better uptake as compared to the. Now, which one was the right and which one was the left? So which one is the right and which one is the left? So my DNB is also here. Manali is right. Yeah. So it's the left kidney which is the hydronephrotic kidney, and the right kidney. So your right is the patient's right and your left is the patient's left. So the left kidney is the one which is on. So this is the left kidney because this is my left. So my left is the patient's left. So this is the left kidney, and the one on my right is the patient's right. Okay? Yeah? Any confusion? Or have I mixed it up? No, this is my right. Yes. So the right kidney is the normal kidney, the left kidney is the obstructive kidney. Alright? Doesn't matter. Okay, can somebody read this now? You have a renogram also now. Would you like to try again?
emitting very small.
Okay. So you can look at these images. These are the pre-void image. This is the post-void image. So this is actually the same study which I had shown earlier. So again, it is your left kidney which is obstructed. You can see that this curve is an upgoing curve, right? This curve is a downgoing curve. So this curve, which is the downgoing curve, looks at your right kidney, and this curve looks at the upgoing curve, looks at your left obstructed kidney. Okay. So sometimes you have this situation where you have a supranormal differential function. So in kidneys which are normal functioning but which have got a large capacious pelvis, your pre-op or your baseline assessment may actually overestimate the contributory function, and this is nothing but just a partial volume. It's an artifact which happens. Why I put up this slide is sometimes you will find a patient who prior to surgery will show 55% and then post pyeloplasty will come to you with a 45%, and the patient will say, Dr. Saab, ye kya kar diya? Hamari kidney kharab kar di. So it is not that. This is just a artifact, and the reasons for that is that these are all finally geometric assessments, right? So you're drawing an ROI and you're trying to calculate how the tracer is behaving within this region, and these are all calculations, and these are the limitations of these calculations. So sometimes you may find this situation where although the kidney is getting better because you've done a pyeloplasty, but the contributory function may actually erroneously be shown as less than the baseline stuff. So this is one kidney where you have a grossly hydronephrotic kidney. So again, can somebody read it? Right, left, पढ़ा दो बस बाकी. हाँ जी. Somebody at the yeah, madam. बोलो 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 ना. It's okay. It's not.
See, right obstructed kidney.
So you look at the delayed images. So which one is this kidney? Left kidney, right? Which one is this kidney? This is the right kidney. So your right kidney is actually a normal kidney, right? So your tracer is going into your right kidney. It is coming into the renal pelvis. So you can see that there is this blob which is out here. This is the renal pelvis, and then it is getting cleared out from the right kidney. On the left side, initially, because it's a thinned out parenchyma and there is no, the cortical function is markedly deranged. So what is happening is that the renal parenchyma is not extracting the tracer. So that's why in the initial study, you barely see anything. So this is like a bag of water, right? And it is only, there is a very thin rim of functioning parenchyma which is there. It's an enlarged kidney, and all this is actually the renal pelvis. So you have this thin rim of pelvis, which you can see somewhere on these images. If you can see on my screen, you will be able to see it better. And in the delayed images, whatever little is being extracted is excreted into the pelvis, and it is all sitting in the pelvis. So this is a grossly dilated, hydronephrotic, obstructive kidney. And you can see that the renogram curve, like what I said, this is a typical type 2 curve, the green one. The green curve is a type 2 curve, whereas the red curve shows a normal excretion pattern. Okay, and then you can also see the contributory function. So if you look at this, you will find that this tells you what is the renal area, what is the percentage uptake. So you find that you see the left and the right contributory function, and you can actually assess how much of the kidney is being, each side is contributing to the renal total GFR. Okay, so now we know the basics. Now we'll just go through some interesting images. So this is a renal cyst. So you can see that there is a little hole out here. if you look at these images, there is this hole which continues throughout the study. So right from the beginning, there is this hole which continues, and this is actually a renal SOL or a renal cyst which will look like this. Okay, this is a very interesting study. Can somebody take a guess? No guesses? So you have this kidney which has got two parts. So the lower part is showing a good uptake and a good excretion, whereas you're seeing some tracer hold up in the upper part. So what is this? This is a duplex kidney. So it's a duplex kidney, which has got. So this is the Wigert-Meyer rule, which says that in a duplex kidney, the upper moiety is drained by the ureter, which actually opens below the lower moiety ureter, and the upper moiety is usually obstructed, and it is the lower moiety which has a reflux. So that is the Wigert-Meyer rule, which says that in a duplex moiety, it is often the upper moiety which gets obstructed, mainly because of because it crosses the ureter, actually crosses the lower moiety ureter, and it gets obstructed. So you can see here, this is the duplex kidney. Okay, so you have the upper moiety and the lower moiety. So the upper moiety is obstructed, whereas the lower moiety is showing a normal excretion. And you can actually pull the system into seeing that there is. So when you draw the ROIs around both the kidneys, then you see both of them are showing a normal drainage pattern. But you can fool the system by drawing an ROI. So this looks at the ROI. If you can see this here, out here, this looks at the ROI. So you have fooled the system into drawing two ROIs, and you find that one ROI is showing obstruction and one is showing excretion. So the lower moiety is showing good excretion, whereas the upper moiety is showing a obstructive kind of a pattern. Okay. So this is got a very interesting name. It's called a cobra head appearance. So this is a uretrocele. So you have one kidney which is a non-functioning kidney, and the other kidney which is a normal functioning kidney. But you can see that there is this something which looks like a cobra head, which is there at just close to the urinary bladder. So this is what a uretrocele looks like, and it's often called a cobra head appearance. Now this is a small child with a vesico-ureteric junction obstruction. So you can see that the renal, while the kidney is excreting, but there is hold up of tracer in this dilated ureter, and that's because there is an obstruction at the vesico-ureteric junction. So this is a VUJO. Now the first image on your on the other side is the pre-op image. The second one is a post-op image, and you can see that as compared to the pre-op image, there is a excretion of tracer into the urinary bladder. So there is no longer a standing column of tracer, which you can see in the post-op image. This is again another situation which you often see. So this is a crossed fused ectopia. I'll show you a better image of this. So this is a crossed fused ectopia. So you have both the kidneys on the same side. You can actually see the two ureters. So you have one ureter here and another ureter here. This is the urinary bladder. So you see the kidney, both the kidneys are on the same side. The ureter is actually crossing over and going onto the contralateral side. And then you have something called a pancake kidney, where you cannot really define the borders of each of the kidneys, and it becomes like one fused central kidney. And this is what a DMSA scan, which actually looks at the morphology better, looks at it. So this is called a pancake kidney. So you see this little blob right in the middle. So the left and right kidneys cannot be separately defined, and this is a pancake kidney. Um, okay, I think we've gone through this. Now we okay. So um, so now we come to the DMSA scan. So like I said in the beginning, DMSA looks at the cortical morphology. So while the DTPA or the MAC3 scan looks at the renal function, this tells us more of the cortical morphology. And these are tracers. The DMSA is attached to the cortical proteins. It is adherent to the cortical proteins, and that's why, because they remain stuck to the cortical proteins, you can actually see the morphology much better. And here you can see that there are photon deficient areas, or there are little defects which you will see on the left kidney, which are at both the poles as well as the interpolar region. So this is a typical scarred kidney. As a scar organizes, it becomes more defined. So you can see that you get a very focal defect in the kidney. The kidney should look like a rajma or a bean. But if there is a defect seen at either of the poles or in the interpolar region, like this patient has had a bilateral polar scarring. So you can see that there is a flattening of the cortical contour at both the poles, and this is a typical scarred kidney with polar scars. Again, you can actually assess this is a progressive deterioration of scarring. So the first one is the baseline. The second one, you find that there is still some haziness and some defects which you are seeing at the poles. And in the third one, you can see that there is a significant cortical defect which you see at both the poles. Okay, these are some interesting images. So this is one patient who's had a ileal conduit, and you can see that the tracer, there is no bladder out here, so there is nothing in the bladder, and all this tracer is going into the ileal conduit, and there is a hydronephrosis of the kidneys. A very interesting case where post PCN there was a urinothorax. So you can there is a urinoma which has gone into the thorax, and you can see this kidney with the PCN tube, and you have this tracer accumulation which has gone beyond the kidney, above the kidney, and this is actually in the thorax. Now these are plain DTPA images. Now today we have the ability to fuse these images with with CT images, so they give you more anatomical definition. But most of renal imaging is imagination, so you do have to extend your imagination to understand that this is the kidney, that is the thorax, so it's gone into the thorax. Now things have become easier, but the whole beauty of nuclear medicine imaging is that it gives you very good functional images without too much radiation. The moment you add on CT to it, you are increasing the radiation burden on the patient. So sometimes when it is required, yes, of course we would add on CT, but there are many things which you can actually assess even without the radiological interface. The same patient has had a pre and post op, and you find that the urinothorax has actually cleared out. This is a ureteroileal fistula. Again, this is you can see that this is a ureter. Actually, unless you know the history, you cannot define. This is the ureter and this is the fistula. In many ways, it looks like a ileal conduit, but this was actually a ureteroileal fistula. You can see it better here. So, to summarize, diuretic renal scintigraphy is a safe, convenient, and easy to perform study. Low radiation exposure, excellent functional assessment. There is confounding factors of dehydration, exposure to iodinated contrast material, extravasation of tracer, bladder dystonia, all these should be factored in. You need a holistic assessment. It cannot be just your T-max, T-half max, and can be complementary to many CT diagnostic studies. So that kind of brings me to the end of the renal diuretic. We have some transplant evaluation, you want to go through all this, I can go through. But if I think there's a lot of, if you just want to go through the images, you can quickly go through the images. So these are, basically you also do reflux studies. So there is something called DRCG, direct radionuclide cystourethrogram. So what happens in this is that we inject the tracer into the bladder directly through a suprapubic puncture, then ask the patient to void. And once you void, the tracer goes up into, in patients who got a vesicular-ureteric reflux, the tracer goes up, it refluxes into the ureter and into the renal pelvis. So this is similar to an MCU. The advantage of this is that one, unlike an MCU where you require catheterization, here you can very easily just inject the tracer. It's a small injection suprapubically which can be given. Secondly, the radiation exposure of a DRCG is far, far, far less than an MCU. So, especially in children where you want to keep these children on follow-up and you want to assess whether the reflux has resolved or not, DRCG is a very good technique because you can do repeated studies without giving too much radiation exposure to the child. This is a patient who's got a bilateral vesicular-ureteric reflux. So you find the tracer rising into both the ureters. And these are the two renal pelvis. So you see, this is the urinary bladder, and the tracer has gone up into both the renal ureters, and has gone into the renal pelvic initial systems. So again, this is a bilateral vesicular-ureteric reflux. So we've already gone through the DMSA. This is what a normal DMSA looks like. This is the pyelonephritis kidney. This is when the scar becomes more organized. So you see a more, more structured scar. The same patient. The patient had a reflux. This is a multicystic kidney. So this is a ADPKD, and you find that there are multiple cysts which you can see in the kidneys, and sometimes a DTPA scan or a DMSA scan may be done to assess what is the functional renal parenchyma, which is residual. So another multiple renal cysts. If you start seeing the liver and the spleen and the heart in a renal scan, then you know that this patient has got a very poor renal function. That's why all the tracer is all circulating in the blood pool and nothing is getting extracted by the renal parenchyma. So again, if a patient has been exposed to any nephrotoxic agent, whether it is iodinated contrast or whether it is any kind of nephrotoxic agent, you will see this persistent blood pool activity and a reduced renal extraction of the tracer. And it's very important to have good quality radiopharmaceutical preparation, otherwise you start seeing all kinds of weird things. Horseshoe kidney, again, something where a DTPA scan or a DMSA scan may be done to assess the function of each of these moieties. And you can see here, both the moieties are function and they are slightly ectopically placed, connected by a band of functioning renal tissue. Now in this situation, one of the moieties is hydronephrotic. So you can see this moiety is normal, this moiety is hydronephrotic. Ptotic kidney. So sometimes you'll have this rare situation where as the patient stands up, the kidney kind of falls down. When the patient lies down, the kidney comes back to its normal position. So this is a ptotic kidney. You can see that the kidney has actually, both the kidneys should be at the same level, but as the patient stands up, his kidney actually goes down. This is an ectopic kidney, a low-lying kidney. So this is not a ptotic kidney. This is always ectopically placed at the pelvic bridge. So the cross-fused ectopia, this is a better scan. So this is a DMSA scan, and here you can see that both the kidneys are fused and they are both on the same side. So you can see that both the shapes of both the kidneys and they are both fused and they are both on the same side of the midline. And you can take tomographic images of the same and this. So I think that kind of brings me to the end of my talk. Any questions, any doubts, anything else that you want to? No. Okay. Right. Thank you. So this presentation is there on the desktop. If any of you want to share it, I'm okay. Okay.
One question. How do we calculate the data based on DNB?
So there is a method called the Gates method. So there are three methods by which you can calculate the GFR. One is the Gates method or the gamma camera method. So what are we doing? We know we have injected this much into the patient. We know the renal, we've drawn an ROI which tells us how much of that tracer the kidney has extracted.
ROI will be same as the whole kidney?
Yeah, the whole kidney. Because the GFR is calculated at about 2 to 3 minutes into the study. So by that time, you don't expect that the kidney has actually started excreting. So you know, you've drawn the ROI, you know what are the counts in that. You can calculate that, okay, if I have injected 5 millicurie, that should have given this much count. So now these two areas, how much of it has been extracted. Okay, based on that and based on the renal excretion, you can calculate. There's a formula by which you can calculate the GFR. It's called the Gates method, right? Then you can also do a more accurate way of calculation of GFR by doing a blood sample method. So what happens in that is you inject the tracer, and then at 1 hour, 2 hours, 3 hours, you can take up to 5 samples, and you can count these samples, right? So you know that the kidney has removed this much tracer from the blood. Okay, so depending on how much is left behind in the blood, you can calculate what was the excretion by the kidney. Okay, so you can actually count these in a counter, in a well counter. You can take that blood sample, remove 1 ml of blood sample, centrifuge, whatever, and then count it and then plot it on a curve, and you have a way of actually assessing what is the clearance of tracer from the blood. Okay, and then hence from there you calculate the GFR. Then there are methods by which you can take the blood sample and the urine sample. Okay, and see that the tracer has to clear out from the blood and build up in the urine. So you take repeated urine samples also, and you see both these things, and with this you can actually so normally, like for instance, when GFR is very, so the problem with the gamma camera method of calculating GFR is that in a fat pig, it's all about there's a lot of calculation, there is a lot of assumption in these calculations, right? So in a normal sized patient, in a 40-year-old 70-kilo patient, your GFR calculation is fine. But if your patient is very small, you may underestimate the GFR. If your patient is very fat, you may overestimate the GFR. Yeah. So in situations where GFR as a value is very essential, like for instance where you're doing a donor evaluation, or in a small child who has a single kidney, you're trying to assess the sequential GFR. In those kind of situations, you should do a blood sample method of GFR assessment, because you will have, or in a patient who is not of a standard size, so a very small patient or a very fat patient. So in those patients, you must do a blood sample method, because that is a more accurate way of assessing GFR.
Sure. Can we differentiate pyelonephritis and scarring based on DNB?
Pyelonephritis and scarring. So an acute pyelonephritis, you will not get a volume loss. So there would not be a cortical volume loss. So you will see the contour of the kidney, but there would be a area where there will be less uptake. Okay. Whereas so that's an acute pyelonephritis. Once it becomes a chronic pyelonephritis, or once the kidney has got scarred, then there will be a loss of cortical volume. So there will be a flattening of the contour. So instead of seeing the outline of the kidney as a regular smooth contour, you will see a flattening usually at the poles, or you will see a peripheral wedge-shaped defect in the interpolar region. So once you see those sharp defects, then you know that this is a scarred kidney. So often patients who are on antibiotic prophylaxis, small children who are on who have UTI, recurrent UTI, and are on antibiotic prophylaxis, and you will see initially that there is some acute pyelonephritis, but then sequentially, sometimes many of the acute pyelonephritis may actually heal without causing significant cortical scarring. And in other patients, there will be significant cortical scarring. So those patients who got significant cortical scarring, those are the patients who have a higher risk of going into renal hypertension or going forward to renal failure.
Ma'am, is there a GFR cutoff below which we should not order these radionuclide medications, DDP and DMSA?
So normally with a DTPA, up to 4 ml of serum creatinine of 4, usually you will get images which can be read. Beyond 4, you should order for either MAG3 or EC. The point is, you have to understand what is it that we are looking for, right? So, if you have a patient of chronic kidney disease who got a GFR of 7, you're not going to find anything. But if you have acute tubular necrosis, or you have an acute kidney injury, or you have an acute obstruction, in such a situation, even if your GFR is high, you may actually get a valid. So it depends on the renal parenchymal function, and whether it is an acute event or whether it is a chronic. So usually, I mean, I don't know which institutes you all are coming from. I worked for most of my life in Gangaram, and Gangaram, at least in one, they would get in their DNB final, they would at least get one renal scan which they had to read. So it's important that you know how to look at a renal scan. You know which is the right, which is the left. You know what is DTPA. You know what is how it is functioning. You know what are the different protocols of furosemide. So they will ask you, and it's something which is very commonly used in practice. So, okay, right, great, thank you.